Okay, now let me share. All right, share this. All right, so today, thrombocytes and coagulation part 2. The first part of this is just a little bit of a review from what we talked about yesterday. So anybody know the term for the body's ability to maintain the integrity of the blood within the vessels, so you don't spill all out and bleed all over the floor? Starts with an H. I'll give you a hint. I know you know because it was on the test, and y'all got it right. This is my shy class. Y'all shy. Let's type in hemostasis. So there's a lot of different things involved. Those pathways that we, the question was, what is the term for the body's ability to maintain the integrity of the blood within its vessels? Well, you're close. Homeostasis is kind of the same, but if it's just pertaining to blood, they just knock it down to hemostasis. So homeostasis is everything in the body just stays even level. So if you're talking about all body systems, we have this homeostasis. We're all homeostasis right now. We're all staying in place. But what's involved, we got all those pathways. We talked about the extrinsic, intrinsic, the common pathway. We did that the other day, so that'll be on the next test. And then, of course, you've got your platelets, or if you want to be specific or scientific, thrombocytes. You've also got these two best friends, thrombin and fibrin. When you see one, you're going to see the other. I call them the besties because I feel like thrombin is kind of like the wingman for fibrin, because when fibrin comes, thrombin tries to like call more platelets in and attract it to fibrin. So you'll always see these two kind of as a pair together. So in order to keep hemostasis, we got 3 phases that occur in the body, so you don't bleed out, because your body it's trying not to die every single day. So we don't want to die. Should I leave those notes up there for a sec? I'm going to move that. All right, so the first thing that happens is the mechanical phase. So I like to think of the mechanical phase as I'm a klutz, and when I fall down the stairs, or actually I trip up the stairs more often than not. Those stairs at school, I swear to God, I have tripped up them at least 12 times and skinned my knee. I've ripped my pants like 3 times doing it. So I like to think of as the mechanical phases. This is when the whole complex actually starts. So what starts it? Let me put my text up here. It is the blood vessel is ruptured or torn. So it can happen internally, it can happen externally. If you trip up the stairs like me, I truly feel like those stairs are just against me, and that's why that happens, but it could just be me. So after the blood vessel is ruptured or torn, platelets get attracted to the surface and undergo a morphological and physiological change. Remember, these guys super love collagen that lives inside of your blood vessels. So when you rupture that, collagen is coming out, and the platelets are like, oh, snap, like I'm gonna go get me some collagen. So it goes and runs over there to the surface. And as they're coming out, I like to think of them with their little pseudopodia as like little hands just like running out to get the collagen. And they also are going through this physiological change. They look different. Um, and once they get there, they can't stick unless they have the glue. So they need von Willebrand's factor. So this guy is the glue. So those platelets could rush over there as quick as can be, but if they can't stick, they're not gonna stick, and that plug is not gonna stabilize, and you're just gonna keep bleeding. I know we've talked about some of the breeds that have this missing factor, so these guys will tend to bleed a lot more often. So you have to be careful for surgeries. If it's a female and she's delivering, have to be careful of that. Dentals, nail trims, pretty much anything. So you really, really need it. But if you have this, what's going to happen is these little guys, they're going to start to adhere to the surface, and then they're all going to aggregate, and then that'll trigger the next phase, which is your chemical phase. So mechanical, everybody's just moving. Everybody's moving to the sites. Um, we've called them to duty, and we said, hey, Ms. Regalia was a klutz again, and she just tripped up the stairs and her knees bleeding all over the place. And so now everybody's like on alert and they're coming in. Does that make sense? You guys are so quiet. Are you tired? Been a long day. Yeah, I thought it was Wednesday. I don't even know what day it is anymore. Like, I'll leave these notes up for another second. I'm gonna grab a sip of my agua, my agua water, coffee. Some of you speak Spanish. What is coffee in Spanish?
Café.
Oh, it's the same.
Yeah.
So I can say I speak some Spanish then, right? But I have to say it with an accent, right? Do you have like a one of those accents over one of the E's?
I don't. I just
No.
say like it sounds the same to me. Well, to me, it's kind of the same.
Okay. Let me clear this off and go to the next one. So I super love this picture. It's just kind of a neat little drawing where it just kind of shows you um, the circles or the ovals are the platelets. Those little rectangles are the pseudopodia, how they're all kind of holding together, forming this bridge to make this clot. The little V is your glue, your von Willebrands here. And this is supposed to represent the blood vessel that's been damaged. The biggest thing that I want you to take away from this slide is that a stabilized platelet plug is lipemic. And we want it to be lipemic because if it's not lipemic, it's going to be really difficult to break down later. We don't want a non-lipemic plug just kind of hanging out forever. We can't break it down. And what eventually happens is it'll dislodge and like, let's say this is non-lipemic. So maybe this piece breaks off because you bumped it. This piece will stick together. This guy will stay together, and then it could potentially go, oh, that's a really bad heart. Um, it could go to your heart, it could go to your lungs, it could go to your brain, and that's when you have the embolisms. So we want that platelet plug to be lipemic so the body can reabsorb it and take it out naturally. We're not going to talk about any of those diseases that cause this to happen. We will talk about some drugs when we get to pharmacology that can actually change these plugs, and then they would have to go on like a blood thinner. You may know some humans that are on blood thinners that enable the body to break these clots down a little bit better. But if the body's functioning normally, just know that that platelet plug is lipemic. Erase that. But yeah, I thought that was kind of a fun little picture. I found it on the Pinterest. All right, so then we get to phase 2. This is our chemical phase. This is where all of that, those coagulation cascade is going on. So eventually that's going to lead to a fibrin clot, well, fibrin mesh, or you could call it a clot, depending on what you prefer. So fibrin mesh, or you could call it just a clot. Ah, clot. So we already said he's got fibrin, he's got thrombin, he's got all of his coagulation cascade working properly. So there's von Willebrand's factor. So this clot is permanent. He is a permanent clot. So he's going to hang out there until the body doesn't need him anymore. And I think I already told you what the answer to this last one is. What factor recruits and activates those platelets? Do you remember? He was the wingman. Thrombin. So he's out there just calling all the platelets in, and he's like, hey guys, Regalia fell again. You better come on and like fix up her knee and her hands. You know, really the only time that I've tripped up those stairs is when I'm wearing my Crocs. I feel like my Crocs are too big for my feet and I trip on them all the time. Maybe I should stop wearing Crocs. I don't know. I'm trying to find my note page here. There we go. All right, let me clear these. All right, so I decided to throw this on here again. So this will definitely be something to look at for your test. So how I'm going to run this test is I usually have it written, but I'm not going to do that this time. So this time what I'm going to do is I'm going to say, oops, what do I want to do that for? Give you like 4-factor, nah, let me undo that. So I'll just be like factor 1 and then give you 4 of these as an option of like, okay, what is factor 1? And you would have to pick one of those, or vice versa. I might put prothrombin down and then say, is it factor 1, 9, 10, that sort of thing. So that's how I'm going to run this test, upcoming test, just for ease of doing it digitally, because otherwise it'd be difficult. This this one here forgot, well, they didn't forget, they just didn't put it in. Don't forget, number 6 is acelerin. Here it says there is no factor 6, but we know, because we're smarter than this table, we know that acelerin does exist. It just doesn't do anything for the coagulation cascade. So if that happens to show up on the test, I'm still using acelerin as factor 6. It's just that it doesn't play any part in the clotting factor. So it's not going to fix my knees after I scrape them up. So don't forget that, little guy. And so now we've rushed to the sites. We've did our coagulation cascade. We've got the glue. We've got a nice strong clot. Everything is patched up. Everything is looking good. Um, Everything is like repairing itself. But once that vessel is healed, the body needs to get rid of it and eliminate that clot. So phase 3 in a normally functioning animal is the formation and the degradation of that fibrin clot. So we want them to get rid of it. So there is a whole bunch of tests that we're going to talk about to see if these platelets are doing their job. Um, there are There's only one platelet function test that is required that you do, but there's some that are super, super fun that we're going to do in class because I think they're super fun. And I have done them in clinic, and I think that, you know, we could do them together too. So we're going to do like 4 different tests. Actually, I think 2 of them are required. So we're going to do like 4. But we want to see that these guys are working, and we can even check for some like fibrinogen and things like that. It's pretty neat, but we'll talk about that in a minute. So when you do these tests, you're checking your platelet counts. You want to see the platelet indices. Are they working? And what the doctor is asking basically for you to let him know when you do these tests is there thrombocytopenia, which means a decrease in platelets, or does the animal have thrombocytosis, which is an increase in the platelets? That's basically what we're kind of looking for once we start all of these tests. Um, Fortunately, the first way to do this is super easy, and it's color coded, and a machine does it for us, and it's fantastic. Um, so that's my favorite way to do it. Uh, my phone keeps blowing up because I'm so popular. All right, let's get rid of my notes here. Sorry. My printer is having some life issues. It prints out like 3 of the same pages. I don't know why. All right, let me get rid of this. All right. So before we even get there, there's just a couple things that I want to talk about because, and this is going to be, if you're not in clinic right now, some of the stuff, I'm going to try and draw it out to better help. And I brought my friend to kind of be a little bit of a, like my helper. This is my animal of the day to show you what I'm talking about. So I basically want to minimize the tissue damage. If I'm trying to assess my platelets, I want to make sure that the area that I'm checking in is not damaged in any way. If this little guy has a lick granuloma, I don't want to use that spot because now the platelets are super attracted to it because he messed with it. If he's got a bite, if he's got any kind of wound, I do not want to go ahead and use that spot because I know there's going to be a whole bunch of platelets there. So when I do this test, it's going to assess just that spot, and I'm going to get an inaccurate result, and it's not going to be ideal. Um, the venous stasis, how many clinic people do I have here? Do I have a lot? I don't know. I can't see you guys. Couple, is there anybody in clinic or had experience drawing blood before? Um,
Drawn blood on a horse.
oh, okay. All right. So when you get in there, so I'm going to draw a vein. So here's my vein, like so. Now I'm going to take my needle and I'm going to poke it. Okay. So now I have intruded into this vein. So when you go in, you're going to be going in at like, I don't know if I'm trying to make sure I'm on the camera here. So if this is my needle and this is my animal, I'm going to go in kind of in a scooping motion. I'm going to make sure I'm lining that up and going straight into the vein. You want to make sure that you don't go and get too excited and go through the the vein, because then now I've damaged the vein on both sides and I'm not going to get any blood. So I don't want to do that. I want to make sure I'm just getting right inside the vein, one poke. And I don't know if you've talked about redirecting yet, um, but whenever I help out with blood draws, and even when I was learning, um, I call it the sawing motion that some people do. They get really nervous. So when you go in to draw blood for the first time, just take a deep breath, just relax, um, try and get into the vein. You can redirect. So if you're just slightly to the side, sometimes you get a rolling vein. So you'll poke it in there and the vein goes, nope. And then you come on this side and it's like, nope. And you never get in there. So you will have to sometimes redirect a little bit. But if you're in there and you go through and through, what I've seen people do is start to saw. So they'll go in and they're like, oh my God, and they draw back on the plunger. They don't get any blood. So they're like, they start doing one of these motions. And just in an effort to like just get any blood they can. And that's usually just relax. Don't panic. Don't saw the animal to pieces. Um, Plus, it dulls the needle. So the more you use that motion, the more painful it's going to get. If you've ever gotten your blood drawn and I'm sure we've all had good collectors and collectors that we were like, oh, good God, like, what have you done to my arm? We don't want to do that to these animals. So slide in, but you're learning. So there is, always room for improvement. I'm still, we all continue to learn. So my big thing is if I see them doing a bunch of pokey pokies and I just settle down and stop what you're doing. And what happens in clinic, you'll have good days, you'll have bad days. Like some days you'll just hit every vein that walks in the door. Maybe the eyes closed. Like that was you know, a pug and you got the single poke on that pug. And then there'll be days where these veins could be like sitting right in your face and you can't hit them at all. So it happens all the time. Um, so basically minimal venous stasis means let's just poke it, get one draw and done. If you're having one of those days where you just can't hit anything to save your life, I would pass it on to another tech. And people do that all the time in clinic. I'm just like, I'm having a day. You poke this thing for me and get it done. Because if I want to assess these platelets, I don't want some sort of sawing motion to activate more to come in. Um, this one, minimal patient excitement. So make sure your restrainer can adequately restrain this pet, because they're going to be releasing a whole bunch of hormones and they're going to be super excited. They may move away from you and then that's going to mess up your venous stasis. So calm them down as much as possible and then go in for the poke. The other thing we don't want to do is use any kind of indwelling catheters, because an indwelling catheter is sitting in this vein, just like the little picture there. And those I love indwelling catheters, especially for your long-term patients, because that'll stay in there. I can collect blood from it, and then also it's got a double port usually, so I can give medication, and then later on I can pull some blood, make sure his liver function is fine, his kidney function is fine. But if I'm doing a platelet count, all the platelets are constantly trying to fix that area because we've introduced something that is unfamiliar. It's not part of the body. So the body is going to kind of constantly be trying to fix it. So never pull the blood from an indwelling catheter, because right around that catheter, you are going to have, oh, I just lost it. You will have excess fibrinogen, fibrin, and platelets surrounding catheter. So when you pull it, you're going to have just everybody's there. Everybody's there at the party. And if I run this, I'm going to look at it and go, oh, well, it's normal. He doesn't have a bleeding problem, but it's an inaccurate result. And also label, label, label. There's only been a couple times that I actually had to do this test on a patient with an indwelling catheter. So if you have to do it, if you have no other choice, maybe this animal has absolutely no blood pressure, and the only place that I can get this blood is from this indwelling catheter, make sure you mark that in the notes so the doctor knows when he looks at it, like, this number is going to be slightly skewed because I had to get it from an indwelling catheter. So these numbers are going to be slightly elevated than what they would be normally. And if you can't do this test right away, make sure you separate the plasma. You're going to spin it down pretty quickly, 25 Gs for 15 minutes. And then there's plastic tubes. We freeze the plasma. And if you need to ship it, most of these tests are going to be shipped off. And then you would put it on dry ice to ship it. So if you do decide to work at a reference laboratory, that would come into play. So just know stuff is going to be coming in on dry ice. Let's see, let me clear all this stuff. Ooh, there's several tests. I super love this picture. It's adorable. This is my favorite one, the machines. It's 2020, so we have all of these automated machines that kind of do our jobs for us, and they're very specialized. We have different tests that we can do for them, um, and they're easy, and most of them are color coded, so if it falls out of the range, it's going to be red, and we're going to look at it and go, okay, this is this one. The big downside to it is if that blood starts to clump, or aggregates, it's going to skew all of your results. So you got to be a little bit careful of that. This guy can also check our MCV, MCH, MCHC, so we don't have to do any of that. But if everything is kind of clumped together, it's going to read the whole span of the blood cells and not just one individual one. So we're going to definitely see this happen because we usually collect our blood on like a Wednesday, and then we'll do labs for Thursday and Friday. So by Friday, when we evaluate all these platelets in the machine, all of our results are in the red because everything has been sitting there. I've had them in the fridge for a couple days. So you're going to see some skewed results. And I saved a bunch of them for you guys so you can actually see what a skewed result looks like. So then we got the manual count. This is using a hemocytometer. I do have some of these. I ordered some new ones. So know that this thing is called a hemocytometer. And this little guy actually comes on his own slide that we reuse. So it's kind of in the center. So this little grid is in the center. And then there's a little channel that you put the blood in, like kind of up here. Depends on which brand you get. If you would look at it from a sideways view, it just sticks up just ever so slightly. So you can still go to 100x and use the oil immersion for this one. Um, but it looks like this. So we would stain our blood with trypan blue. At school, I use new methylene blue, which is just as fine. They're both super vital stains, so it works. So then you put that in there, and then you would read this. So basically, we're looking for aggregation, which we already know everything is clumping, and then giant platelets. So that's what that middle section, like this area here. Um, so we want our platelets to be, let me change it to red. So we want them to be just like little itty bitty ditties. But if they happen to be bigger and they're covering like several um, squares, we know we've got some giant platelets. And just like your RBCs, they always start out bigger when they're babies. So those giant platelets aren't really doing their full job yet. So that's a hemocytometer. And so I am not making you do this math. This is not technically a required skill. You're required to know what it is and how to use it. So what I usually do is I set a couple of these up for you guys to look at, so you can see what the platelets look like in there. The last couple terms I haven't been able to use them because they got cleaned with alcohol. So the alcohol just destroyed the plastic, but I have some new ones ordered. So hopefully by the time we get back, those will be in, we can use them. And I'll set those up for you guys. But if you do go to work at a reference laboratory and have to use this, they're going to retrain you how to do it. But you're just taking an average of the cell count, and then you multiply that count by 10,000, and then you have to multiply it again by 5, because when you stain it, it's a 1:5 dilution with the trypan blue. So it's going to be a huge, huge number. So everything with the dark area are the squares that you count in. Where's my line? Draw. So everything with this dark area you would count, and then anything with the dashes you don't count. So I would count here, and count here, and I would count. Oops, that's a little bit off. And in these other ones, these areas here, I'm looking for aggregation giant platelets. So in these areas, but I am only counting in these solid line areas. But don't worry, I am not making you do this math. I feel like I have mathed you guys to death a little bit, so I'm not mathing. This one we will definitely do. We are doing the platelet estimation. So I usually do this in combination with the white blood cell count lab. And I have lab sheets for you, and you're going to have to look in 10 different fields and count your platelets. So if we pretended this picture here was our first um, field, then we would go ahead and count them up, and I would say, okay, well, I've got 1, 2, 3. So on your lab sheet, I'll have it numbered 1 to 10. So I would just write down 3. And then I would go through and count the rest of my 10 fields. And then you're going to add all 10 fields up. And then you're going to multiply it. At VTI, we use 18,000. Some books use 15,000. Some say 20,000. So at VTI, we came to an agreement that we're going to use 18,000 because it kind of cuts it straight in the middle. Surgery uses 18,000 too, so when we make our binders, I'm going to put 18,000 in there for you guys, so you have that, and it's consistent from ClinPath all the way through your time here. But this one it's pretty easy. I think the biggest problem people have with this one is they forget to count their platelets while they're counting their white blood cells. So don't forget your platelets. There is another way to do this estimation, but this is not my favorite method. I feel like this one is just a lot more work, and you get the same number as you would with this one. So with this one, you're counting all the platelets. The whole time you're counting your 100 white blood cells, every single field you go to, you would count how many platelets. And then you would take that number, multiply it times your white blood cell count that you get from the machine, and then divide it by 100. And because you're counting such high values, it's going to be really, really similar to this number. And with this one, you only have to count 10 fields, and then you're just kind of mathing it out, getting the average and multiplying it. So this is the one that we're going to do in class. This one, you can do this one if you want, but it's a lot of extra work, and I work smarter, not harder. So I just like to let you know that if you go to a clinic and they're doing it this way, they're not wrong. It's just takes longer to do it. So, and actually, this is where I stopped in the other classes. So I think we will put a pin in it here so we don't